So one of the most common and devastating causes of legal blindness is that of macular degeneration. And most people at risk of this don't even know that it's slowly developing in their eyes, making it super important to do everything we can to prevent getting macular degeneration, but also detecting it early and then, as eye doctors, prescribing treatment to stop it or slow it down as soon as we can. And on today's episode of the Dr. Alex podcast, we are joined by Dr. Carolyn Majcher, who is a professor at the Northeastern State University, Oklahoma College of Optometry, where she not only focuses on retinal disease, but has published many papers and research on various retinal diseases, and gives many lectures and consults for many of the companies that help design new technologies and treatments for retinal conditions like age-related macular degeneration. But today she shares not only what macular degeneration is, but the early signs and symptoms that we have to be paying attention to different technologies that doctors are using to catch these diseases earlier, and the newest treatments that are coming out for age-related macular degeneration, including not only lifestyle changes, but new injection treatments that are available, and even red light or low-level light therapy, also known as photobiomodulation. This episode is going to be jam-packed with information. I'm really excited that we have someone like Dr. Majcher to help us through it. And if you happen to find value in this content, please do us a favor, hit the subscribe or follow buttons either here on YouTube or on your favorite podcasting platforms. That way you don't miss any of our future content. Otherwise, with that being said, let's dive into it. Dr. Majcher, thank you again for jumping on here to the podcast, sharing some of your expertise and time. So we're going to be diving into macular degeneration. Certainly we have a lot of doctors and students who are listening in, but we also have just viewers, consumers, people who maybe are struggling with AMD. Maybe their doctor told them that they were diagnosed with macular degeneration and they're like, what is this? I don't even know what this is. So can we just kind of level the playing field and in your own words, how would you define or explain what macular degeneration is?
Yeah, I think it's really important we talk about macular degeneration. We actually put on the sort of qualifier of age-related macular degeneration because it is sort of like accelerated aging of the retina, like this, accelerated wear and tear that typically occurs, but then there's risk factors that make it occur faster. And typically when we're talking about age-related macular degeneration, it's affecting individuals over the age of 50. And there are many kind of risk factors that come into play with regards to what causes macular degeneration: aging, genetics, oxidative stress, like smoking, there's lifestyle factors. So many things come into play that, it's interesting. And as a medical profession, we're still trying to understand what exactly the disease is and what the driving factors that fuel the disease are. But it's essentially a progressive loss of the central vision, which corresponds to the macula, which is like the central part of the retina, the film of the camera that lines like the inside of the eye. And I typically kind of explain to patients that macular degeneration results in sort of like an impaired toiletry system of the retina, where there's a buildup of waste products that occur and it can't get rid of the waste products. So we start to form these deposits called drusen in the retina that is like a hallmark early feature of macular degeneration.
I know I love that explanation. And I think of it very similar because I always try to explain that the retina is the most highly metabolic tissue per unit area, considering how much blood flow goes to the eye. And because of all that metabolic waste, right? There's a lot of oxidative stress from light hitting it all the time. That waste has to be cleaned up. But if something is dysfunctioning and it's not getting cleaned up, then that waste builds up and then your body deals with more inflammation because of that waste too, right? There's an inflammatory factor that comes into play with AMD, which I think some of the new medications are now trying to target that, which hopefully we'll dive into a little bit. But you were mentioning the drusen, so that's one thing I know as eye doctors we're trained early on to recognize, like if there is drusen building up. Can you explain not only drusen and maybe the size of drusen, but like other kind of early signs of macular degeneration?
Yeah, I'd say like the two classic hallmark features of macular degeneration on clinical examination, that is drusen as well as what we call pigmentary changes. So the RPE, or the retinal pigmented epithelium, is a pigmented layer that is underneath the retina and provides it a lot of support. And so when the RPE becomes damaged, then the photoreceptors of the retina can't function correctly because they don't have the right support. There's nobody to kind of suck away those waste products, which build up as drusen. And so drusen usually on clinical examination appear as like yellowish type of deposits, usually underneath the RPE, or can also be underneath the retina. There's different subtypes. We consider a large drusen to be greater than 125 microns. And one large size drusen would automatically put you into what we call intermediate stage dry macular degeneration, which is a little bit higher risk to go on and to progress to advanced forms of the disease. When it comes to pigmentary changes, so these changes in the RPE layer, they can be either what we call hyperpigmentary changes. So in clinical examination, they look like more brown, darker changes in the retina, or they can be hypopigmented changes. So the RPE can become so damaged that it starts to like attenuate or thin and atrophy away, and you start to see right through the retina and through that area of missing RPE down to the sclera where it's like white looking. And so it could be hyper or hypopigmented changes. Again, those, when you have pigmentary changes, that pushes you into like a higher risk category of macular degeneration.
Right. And so I know when I'm in the clinic and I'm looking at the back of the eye, certainly I think, drusenoid changes are oftentimes the first sign that I'm seeing, right? Patients may have other symptoms, right? We know night vision or poor vision and low light is sometimes a symptom, which I think is confusing sometimes from a doctor's standpoint, right? Because we're also thinking, okay, well, they could be struggling with cataracts, right? If someone comes in saying they can't see at nighttime or they're having trouble driving, you're thinking, okay, it could be cataracts, but it could also be maybe something dysfunctioning with the retina, such as AMD.
Absolutely.
But then we have more advanced stages, like you mentioned, right? There's certainly geographic atrophy in dry macular degeneration. The advanced. Let's actually break off into that first. Let's talk about dry versus wet AMD, because there's two different types, the major types that people think about, and then we have kind of advanced stages of both of those.
Yeah, certainly. So I think it's probably easiest to start on what is wet macular degeneration, which is the less common form of the disease, thank goodness, because it causes the most vision loss. But usually when we refer to wet macular degeneration, it's an eye that's under so much stress that it creates new blood vessels. And so these new blood vessels, or neovascularization, we call it, pose a problem because they're very weak and leaky and fragile compared to normal blood vessels. So they can very easily break open and bleed. So patients may suddenly lose vision because these neovascular membranes cause a major bleed within the retina, an area of blood that we can actually see on clinical examination as doctors as well. They can also just leak out fluid. They can leak out like what we call exudates, like lipid kind of cholesterol deposits that are usually in the serum of the blood. So it's usually that exudative form or wet form, neovascular form. It goes by several different names that causes severe vision loss from macular degeneration. Whereas when we talk about dry macular degeneration, the early stages, we just have like drusen, maybe some pigmentary changes. In more late or advanced stages of dry macular degeneration, it's characterized by loss or atrophy of that RPE layer that then is followed by atrophy of the outer portion of the retina, or the photoreceptors, what we call geographic atrophy. And so when we talk about advanced macular degeneration, that term is usually referring to a patient that has neovascularization or exudation present or has geographic atrophy present.
Right. And those more advanced cases reflect also the higher risk of significant vision loss too, right? Because
yes.
If somebody has geographic atrophy, it's basically like you're looking at a part of the retina that's gone, right? You're just it's usually hypopigmented with some, areas of hyperpigmentation around it sometimes.
Mhm.
But you're just looking like straight at the sclera. It's like the retina is gone.
Yep.
Um, and so somebody's vision, you're like our patients will be in, and they'll be like, maybe their vision's blurry at first, but some patients come in and they're like, I have just a blank spot in the central of part of their eye, which is so frustrating, right? My heart always kind of
Yeah.
goes out to our patients who are struggling, because like I know you and I both probably love to read. We love to read articles and maybe new books and stuff that are coming out. And I always think, gosh, how difficult life would be if I could not see the letters I'm trying to read in a book or something. Thank goodness we do have low vision specialists who can help people in a lot of cases, right? Not just large print text, but now with technology and magnification devices. So what I was kind of mentioning earlier when we were talking about drusen and that hyper and hypopigmentation in the back, I've shared with you before, like I'm starting to recognize some patients that don't necessarily have drusen in the retina, but they will have changes to the pigmentary levels of the back of the eye. In fact, I will catch them using some advanced imaging techniques that we have in the clinic. Our clinic does have fundus autofluorescence, for example. Can you share kind of your experience with fundus autofluorescence and where does it come in like clinically in your practice?
Yeah, I'd love to, but I'd love to backtrack and talk about that patient you just described that has pigmentary changes but doesn't have drusen. My first question is the patient over 50? Because if they're under 50,
Mm.
it's probably not AMD for sure, right? If it's a patient over the age of 50, I'm looking in both eyes. So is there drusen in either eye? If it's just pigmentary changes only, I'd be thinking about like mimickers. So like, could this be like you're saying central serous, some pachychoroid disease I could pick up with FAF imaging? Could this be past trauma? There are a lot of other things I would consider if it's solely pigmentary changes.
Yeah, no, thank you for mentioning that, because I in my head, I think a lot of practitioners, when we're thinking and talking about one kind of disease state, it's like we sort of already are making that assumption that I'm talking about somebody who's older. But yeah, absolutely, because I've had people who are younger, and I'm like, why do you have more pigment in one eye than the other? And again, at that time, I'm probably thinking something like central serous, or maybe they've had previous episodes of something. But in this particular case, this was a patient who is 68, 70 years
No.
old. And so, yeah, it was one of those cases where I was quite happy I did this additional test, because otherwise, just fundoscopically on examination, it doesn't seem like there was much going on, except I had already a warning tip off because their vision was reduced. Their best corrected vision
No.
in that eye was not getting better than like 20/30. I was like, there's got to be something going on.
Mhm.
But still, yeah. So as far as, like imaging techniques that we have available for examining the retina beyond just dilating the eye, looking inside, what has your experience been with things like fundus autofluorescence and maybe OCT?
Well, incredible. I think like multimodal imaging is absolutely critical to incorporate as a, eye care provider to detect the earliest treatable macular degeneration possible. Like even like the patient you're describing, like maybe that like when you're looking at the fundus, there's no drusen, but then you actually see that there's subretinal drusenoid deposits, which are like a subtype of drusen, can be incredibly subtle on clinical examination, but then you're going to see it on OCT, or you're going to see it on, say, like fundus autofluorescence imaging or near infrared reflectance. So incorporating those imaging modalities is really important. Fundus autofluorescence, I think, is particularly important for looking for early geographic atrophy in addition to OCT. So if I'm looking for geographic atrophy, like OCT and FAF are my go-tos. And pretty much on every follow-up in a patient with macular degeneration, I'm doing OCT. But then fundus autofluorescence, I'll probably do every like 6 to 12 months, depending on if they already have geographic atrophy present, or they're at high risk of it, from what I can tell looking at the imaging. But OCT, like hands down, the best way to detect early exudative neovascular AMD. Like there can be such subtle fluid or such subtle thickening, like under the RPE, that we can't see it clinically. And you have to have OCT if you want to be able to pick up the earliest neovascular exudative AMD. And we know that the sooner you get treatment on board with like anti-VEGF therapies, the more vision you can preserve and the better the visual prognosis. So catching that like early conversion to neovascular wet AMD is so critical. And imaging really allows us to do that.
And as far as kind of not just we have OCT, but now in the probably the last decade, OCTA has come out. And I think there's a lot more publication and utilization of that now that clinics are starting to upgrade and adopt the new angiography technique.
Mm-hmm.
You have pretty extensive expertise in that too, don't you? I think you have a couple of lectures on it.
Yeah, and I've been using that since it first came out. So I have at least probably 10 years of experience in OCT and geography at this point. It is so valuable in directly visualizing the membrane itself, not just the secondary effects like fluid or blood, right? And so we can actually pick up these membranes before they leak out fluid, before they leak out blood with OCT and geography technology. And really, if you have a membrane that's what we call non-exudative, OCTA is the only way you can really monitor that over time to see, is it increasing in size or how is it changing?
Right. And for again, of all of our listeners and viewers who are like, what is this OCT thing they're talking about? This is a technology, an optical coherence tomographer. It's basically the way I always describe it is kind of a fancy way of doing. It's kind of like getting you could say MRI, but so I've heard other people describe it as getting like an ultrasound of the eyeball. But high definition, right? Because we can see individual layers. That's one of my favorite things to show patients in the clinic, in fact, and like walk them through like what we're seeing, because you can see the individual different layers of the photoreceptors and really the retinal structure. And if there's really subtle disease, like you were just mentioning, if there's a small amount of either subretinal drusen, or if there's a small amount of leakage or a new blood vessel that's leaking in underneath the eye and underneath the retina and leaking fluid, like it's nearly impossible for the human eye to see that subtle detail just looking inside the eye. Mm-hmm. And it's it's great to have that technology, and the fact that it's improved over the many years, right? When now it usually only takes maybe a few seconds. Once the patient gets set up and sitting in the instrument just right, the scanning lasers it takes just a matter of seconds to take these images. As far as like examining it or looking for disease, is there any other kind of either techniques or kind of things that you find most useful in your practice assessing for macular degeneration?
Yeah, so certainly like OCT, angiography, color fundus photography is important. But I think fundus autofluorescence is going to highlight more like subtle changes to the RPE. I utilize like a review software analysis so that I can like look at multiple serial OCTs over time to see if there's been changes, or I can also look at serial like near infrared reflectance images, which is just like the grayscale photo that usually comes when you take an OCT. So you can look across. That's actually a great way to look at geographic atrophy progression over time, to visualize subretinal drusenoid deposits even, and see how things are changing over time. So I think review software algorithms are important too, to look for changes, especially when you're undergoing anti-VEGF therapy, which, usually as optometrists we're not doing, but you can actually see like a reduction in retinal edema and thickening with successful treatment. And it can help guide, well, when do I need another injection, right? Has the fluid recurred? Has the edema recurred? I think an up and coming thing is like AI analysis software algorithms, especially for like OCT imaging. It's already out there. It's just not very commercially available or user-friendly, in my opinion, right now. And it's tough to also, as a provider, figure out how can I be HIPAA compliant by getting an OCT scan and uploading it to this cloud-based server that does the AI analysis. I think there's still some hurdles we're jumping through, but it's incredible how you can, put an OCT scan through this AI like program. It'll list for you all of the biomarkers for AMD progression that are present. And so you can monitor that over time. It'll tell you if there's geographic atrophy. It'll tell you if there's subretinal fluid. It'll actually go so far as to give you a hint as to like this patient's likely wet, or you know what I mean? Like it is very impressive.
Yeah, I know our clinic that I practice at right now, we just started signing on to an AI program that will evaluate like fundus photos. And I'm not sure to extent how the AI is going to be reading, because we also will check FAF, and we'll also have like a screening OCT with that.
Oh, nice. Mm-hmm.
And so I haven't used it or seen it yet, but I know we just signed on. So maybe in the next few months, I'll be able to, if I run into you at one of our conferences, maybe I'll let you know how it's coming along.
There'll be some rudimentary things that are going to become embedded, I think, in OCT devices that are commercially available. But the good AI programs are going to be standalone things because they don't have as many hoops to jump through FDA, as I understand it. So it's like you purchase the license online, you take the DICOM file of the OCT, upload it to that, and it analyzes it. That's going to give you, I think, the best analysis possible versus what's available on the machine. You know what I mean?
For sure. As far as like you kind of mentioned anti-VEGF, right, as a treatment, certainly. Could you, I think doctors listening in, we know anti-VEGF, it's been around for some time. For people who are listening in and are not really sure what that is, can you just spend a second kind of explaining what anti-VEGF is, when it gets applied?
So anti-VEGF stands for anti-vascular endothelial growth factor. And these are medications that are injected into the eye via what we call an intravitreal injection. So we put the needle through like the white part of the eye to actually get the medication inside the eye where we need it to work on the retina. And this is a common treatment that's utilized for neovascular or wet forms of macular degeneration. And I like to think of it as like killing two birds with one stone. So it decreases this new blood vessel growth. So remember, in wet AMD, we have these new blood vessels that are the problem. We can actually try to shrink and shrivel those down with anti-VEGF medications. It also is like decreases vasopermeability, so that blood vessels that are there are less likely to leak out fluid or cause edema, cause bleeding in the retina. So it works in kind of both of those ways. It's a therapy that right now there's, tons of different anti-VEGF medications out. Some of them are more durable, like last a little bit longer than others. But yeah, when it first came out, gosh, let's say, what was this, 2007? Like just revolutionized treatment of AMD. But used to be, we would just literally laser the retina, which is like barbecuing, destroying the retina, creating a massive scotoma or blind spot in these patients' vision in an effort to try to prevent them from going blind. So with anti-VEGF therapies, we can oftentimes even improve patients' vision, which is awesome.
Right. And I have some patients I know who, I think the reality is anytime you think of a needle coming toward the eye, getting an injection is frightening. It's, they use it in horror movies. But we know as practitioners, like, one, the eye is numbed, it's cleaned. They do betadine to make sure you don't get an infection. You look away from it. And now they even have like devices that cool the insertion site and things like that. And I mean, other than a little bit of pressure, most people don't really feel anything in these procedures. And I always try to remind patients, because sometimes they're like, I don't want to go, like they don't like the experience of getting it. But I'm like, this is your vision. Like this treatment can dramatically improve your vision from one position. Like if they're seeing very poorly because of a new wet macular degeneration, like this is the best treatment we have. And yeah, you're going to be probably getting this injection maybe every month, every 6 weeks, every few months, depending on what the specialist is finding, how they react. But like it's important. It may be a tough, it's not comfortable, but it's the amount of benefit I think you get, the cost benefit ratio is so good. So I do always encourage patients and try to do that extra moment of conversation. Like if I'm referring a patient to see Retina to have a possible injection, I try to tell them, like, this is super important that you go and try to keep following up with the retina specialist. So.
I completely agree. I think patient education is really important, especially in like giving them a heads up that it's chronic therapy. Because whether it's like complement inhibition for geographic atrophy or it's anti-VEGF for like wet AMD, you're looking at, a series of injections probably over years, right? You're not looking at just like a one-time injection. So I think it's really important to set realistic expectations and discuss, they're relatively safe, a low side effect profile. Most patients I've seen get upset about when they get like a subconjunctival hemorrhage because it just looks terrifying. So I've started telling patients like up front, like it often happens they get like a blood spot on the white part of your eye. It's nothing to be worried about. That way they don't get concerned about something like that.
Yeah, that's good. Yeah, I don't think I've ever really talked to my patients about that, but that is true. You also mentioned the injections for geographic atrophy, which is it's been out for what, 4 or 5 years now? I think at least 3 or 4.
Yeah, I want to say 2023 February maybe.
Yeah, can you speak to some of these new treatments specifically for geographic atrophy?
Well, certainly. So FDA approved right now. We're looking at complement inhibition therapies. So these are administered again via intravitreal injection, either every month or every 2 months. And they work on the complement system. So we think inflammation is linked to macular degeneration in many ways. And so this is kind of working on some of those inflammatory pathways that we think are dysfunctional or have gone like haywire in macular degeneration. These particular medications only slow the progression of geographic atrophy. Maybe back up for a second and just talk about geographic atrophy. So, geographic atrophy, where we have loss of the RPE, loss of the outer retina, is an irreversible thing. Like once we lose tissue, like it's gone forever. And unfortunately, geographic atrophy and macular degeneration is a progressive disease. So over time, like you'll have this area of geographic atrophy that's expanding, or there's multiple patches of geographic atrophy that like coalesce. And so if we can treat early and prevent further loss of retinal tissue, further loss of vision, that's the most ideal place to be, right? I like to think of it as much like we're always trying to catch glaucoma as quickly as possible. It's the same reason. It's right. Once you lose nerve tissue from glaucoma, like it's gone forever. It doesn't recover. It doesn't regenerate. This is a similar thing. Like once the retina is dead and gone in geographic atrophy, it's gone. So we're trying to pick it up early. So these complement inhibition medications slow the progression of geographic atrophy by probably like 20-30%, depending on the particular individual characteristics. It doesn't improve vision. It doesn't halt the disease process in any way. So I think you just need to set realistic expectations for a patient undergoing these types of treatments. But at least we have something available, because it wasn't until a few years ago we didn't have anything to treat geographic atrophy, unfortunately.
Right. I think that is kind of a tough reality because once you hit geographic atrophy, your chance, everybody kind of, I think, proceeds at a different rate, or it's very individualistic, but a lot of times it's like, oh, within 5 years, your chance of hitting legal blindness is rather high. And so if you can delay that 20 to 30% year after year by getting these types of injections, like that might equate to several extra years of functional vision to still see friends and family, to still be able to read and function. And that gives you more time to adopt, or I should say adapt, to the lifestyle changes you need to make with vision loss to still be able to live a happy, functioning life. So I think that's another way to think about it too. Like it gives you more time, make those adjustments.
And I find that patients are usually most concerned about like losing the ability to drive, because then it's like social isolation, you lose your independence. And so if we can buy you like a few extra years of driving, that can be highly fortunate. And I think sometimes too, patients don't always think about the burden that vision impairment or vision blindness like has on their family and their caregivers, their loved ones, who then has to start doing things for them. Like if you forgo a treatment, not only does it potentially hurt you, but it may also place an undue burden on, individuals who are caring for you.
Now, I know when these medications were first coming out, I started referring patients of my own that had geographic atrophy to the local retina specialist. And then I found out that they weren't offering those treatments just yet. It seemed like
Mhm.
there were some specialists who were a little bit more slow adopters. But now it's been, 3 years or so. Have you seen an increased amount of physicians who are prescribing and treating patients with these now?
I have. I think it's because we now have longer term data from some of the clinical trials that are demonstrating that, of course, there's risk, but it's like generally safe, generally effective. I think the initial hesitation from a retinal specialist standpoint was multifactorial, but one being that it decreased the progression by 20-30%, which isn't a whole lot for the burden of and the cost, right, of having to do injections every month or every 2 months. And then there were, some concerns potentially about inflammation, and then potentially about accelerating the conversion to wet macular degeneration. But we now better understand that patients who do convert to wet macular degeneration, you can undergo anti-VEGF injections and complement inhibition therapies concurrently at the same time. So,
Hmm. I wonder. Yeah, I have no idea. I haven't seen any research on like what happens like to the rate of improvement or stabilization when they're getting them at the same time. That's something I'll have to look into and see if there's anything published on that.
I'm not
Um,
sure offhand, but
yeah, but I think that's something to look out for because I'm sure there's studies ongoing, right? Somebody's going to be publishing on that.
Mhm.
I think one of probably in the last 2 years, it's become quite fascinating to study this, and it's not without its criticisms. Uh, but now we do have an FDA approved red light therapy uh, for treatment of macular degeneration. And correct me if I'm wrong, but I believe it's only for dry AMD at this time. Do you know much about that technology and kind of what's going on there?
I do, yeah. I think rather than using the term red light therapy, because like part of it is red, but there's several
Mhm.
different wavelengths, like some that are more like yellow or near infrared that can be effective. So like low level light therapy or photobiomodulation is a term that's really like picked up interest. And so some of the studies done doing this particular device called the Valeda device, which was developed for patients with macular degeneration, looked at its ability to decrease progression and improve vision. So, actually, getting some visual acuity back in patients that did have dry macular degeneration. And patients in those studies also had to have some like decrease in acuity, like 20/30 or something like that, right? So actually, we're looking at how many patients could actually regain vision and could we slow the progression of the disease. They found some really interesting things in terms of not even improving vision, but also reducing drusen volume. So we're getting rid of some of the drusen. And also, what I found really interesting was like a decrease in the risk of developing geographic atrophy, which was really impressive, right? So if we can prevent you from getting GA in the first place, like that's the best option. I think there's been, some delay in the rollout of the Valeda device. There's other low-level light therapies that aren't necessarily FDA like authorized or approved to treat macular degeneration that people are using to treat macular degeneration. So it's like an ever evolving sort of management thing that's going on right now.
Yeah, I think because I got really fascinated with this red light. In fact, I have another podcast interview set up with a researcher who is involved pretty heavily with the development of the Valida system. So I'm
Oh,
going to be
wow.
I'm going to be bringing him on and asking him tons of questions. Uh, but I know when I first started reading in on it, I was fascinated by it. Of course, the early clinical studies coming out. They only had small sample sizes, right? It was like 20 people in the study, maybe 50, maybe 100 or so. So it's always like taken with a grain of salt, like this is a small study. But yeah, the data of geographic atrophy reducing by like 20% and the drusen volume and seeing images of like drusen just disappearing. It's like,
Mhm.
we've never had this before. So,
Yeah.
um, and it's not speculative, right? It's like now there's hard data coming out. So I still always put that disclaimer that like this is still early. We still have probably a lot of research to go. But it's exciting, I think, for our patients, and certainly exciting for us as practitioners, that we have more to offer our patients beyond
Mhm.
just, hey, certainly if you have advanced AMD, we need to do injections. Um, and when you have just mild or early signs of the disease, more than just, hey, take these supplements, right?
Yeah, absolutely. And I think we should be choosing select patients for this photobiomodulation therapy, which we're trying to get like off the ground at the school right now. So we're going to be implementing it here very shortly. But individuals who have intermediate stage dry macular degeneration versus say like early, if they've decreased acuity, like even better because they're probably going to get some vision back, and then have like high risk factors for progression. So patients that have maybe like impending geographic atrophy or a lot of subretinal drusenoid deposits and soft drusen on OCT imaging, or pigmentary changes and hyperreflective foci on OCT, right? If we're seeing these biomarkers for progression, that's a patient that's probably going to benefit more so than, somebody who's low, like early dry macular degeneration. But I
Right.
think it's really, really exciting. Yeah, to have a therapy to offer. I wish insurance paid for it. We're getting there, I guess.
Yeah. I mean, that's just a reality with any new treatment, right? Any sort of new medication, new therapy that comes out, it always takes a few years before insurance will even consider covering it. But
Yeah.
I imagine if it turns out to be as good as it is, in time, I imagine there will be, I hope there's some insurance coverage for it. But I'm not involved. I don't know the politics of that. But there's, I can cross my fingers and hope for it. Off the
Mhm.
top of my head, I think I recalled the Light Sight 3 trial for vision
Yeah.
improvement said that like almost 50% of patients receiving the full treatment had at least one line of
Yep.
improvement
Mhm.
on like ETDRS chart. And then I think it was like maybe 20% of people had 2 lines of improvement, and then 5% or so had like 3 lines of improvement in their visual acuity, um,
Mhm.
which is that'll bring somebody from, not being legal to drive to being legal to drive again.
Yeah.
Uh, we'll have to again see how long does that last, right? How powerful is this improvement, and how far off can we push blinding disease progression? But
I
it's an exciting time.
think much like anti-VEGF treatment or complement inhibition treatment, the expectation needs to be that this is chronic therapy if you want to maintain that vision gain. I can't remember exactly the intervals they did it in that Light Sight 3 study, but it was like a series of sessions that then they gave a break, then repeated it again. So you're probably looking at sessions like every, I don't know, 4 to 6 months or something like that if you want to maintain that improvement.
Right, and that's I think what they found in those trials using that specific device, using those specific wavelengths and energy profiles.
Mhm.
So we'll have to see. Yeah, as time goes on, are they going to find that, hey, you need to have this every 6 months, but maybe they'll find increasing the energy or decreasing it, something might be safer. I'm not
Yeah.
sure. As far as lifestyle factors for your patients,
Yeah.
what's your kind of way you educate your patients about, whether it be starting to take ARED supplements or smoking? What's your conversation like when you educate your patients?
Yeah. So I recommend an AREDS either 2 or like 3 type of supplementation for individuals who have intermediate stage macular degeneration in both eyes, or maybe they have intermediate stage in one eye and then advanced in the fellow eye, whether that's GA or neovascular. I typically don't recommend any sort of supplementation for patients with early stage macular degeneration. That's just me by personal choice. That's a lot, much longer conversation to have than this podcast. But then a lot of other things, certainly, the top modify or the top risk factors are unfortunately non-modifiable, which is age and then your genetic makeup. But the most important modifiable risk factor is smoking. So if patients smoke cigarettes, obviously counseling them to stop that. I think it increases the risk of developing AMD by like 3 or 4 times, and then it makes you more likely to progress and go blind from macular degeneration if you're smoking when you have it. mean, there's so many reasons why you should stop smoking, but macular degeneration is a great one because you don't want to lose your vision.
I was just going to ask, being on smoking specifically, do you know, I haven't seen anything specific publicized on it, but do you have thoughts or do you know about secondhand smoke or vaping, right? Because that's where people, a lot of, especially younger generations, have transitioned from smoking cigarettes or cigars to vaping. I don't know if we have anything on that.
Secondhand smoke, I don't know if there's been research done on it, but I often do, like in my education of patients with macular degeneration, tell them to stop smoking and avoid secondhand smoke at all possible. There has been some research done on vaping, and vaping can also increase the risk of macular degeneration or any tobacco, input in any method, right, can cause vasoconstriction and oxidative stress, promote inflammation. And so vaping still poses a risk, although it's probably less than smoking because there's so many additives in cigarettes and that, but still increases your risk of developing and progressing AMD. So you should try to avoid it. My conversation with patients too, and I created like a little handout that I give patients when they're newly diagnosed with macular degeneration to go over all these lifestyle factor things because there's so many to remember. But one of them is also UV protection, like when they're outside. I talk to them about dietary things. So a Mediterranean style diet. So high in like fruits and vegetables that have, vitamins, antioxidants, minerals in there, especially vitamins like A, C, and E, things that contain high carotenoid levels like lutein and zeaxanthin. So these are usually things that are like yellow or orange colored, like bell peppers, like egg yolks are a good source of lutein too. Asking them to avoid fatty foods, especially like those that are highly processed and have like a lot of unsaturated, saturated fats within them. Important to avoid that as well. And then usually recommend some high omega-3 fish 2 to 3 times per week. So this is like salmon, mackerel, something like that.
Mm-hmm. I'm glad that you mentioned those because those are things I talk about like on the YouTube channel pretty regularly. Because I have my own fascination with nutrition and trying to better understand like what can we do lifestyle wise to prevent disease. But those are all spot on. So thanks for mentioning those.
I don't think supplementation is going to get rid of a bad diet, right? I think in patients that have intermediate stage AMD, like it goes hand in hand. You have to, I think, supplement to get the really high doses that have been proven to reduce progression. But then your diet also is very, very important.
Oh, well put. I'm glad that you emphasized that point. Certainly, so we have AREDS 2 supplements have been out for some time. Now AREDS 3 is kind of around the corner. We don't have to dive too much into that because I think that a lot of that research isn't quite, I don't know how much is released at this point. But that is an interesting thing. Do you know much about that or what's going on?
Yeah, so the AREDS 3 supplement that Preservision released, it contains some additional B vitamin complex. But what I do like about it is they reduced the level of zinc from 80 in AREDS 2 down to 25 in AREDS 3. And then the rest of the components are the same, I believe. I would start recommending it just because they reduced the level of zinc. I like that a lot. But it kind of implies that there was like an age-related eye disease study 3 that like proved that this could be effective, and there wasn't, right? So I think doctors and patients need to be aware that that's not really backed by some high clinical research trial or anything like that.
Yeah, from what I understand, they've compiled a bunch of other new data from other studies, and they use that as a inspiration to be like, hey, let's put this together. And now I believe that's probably what they're going to be using in the next phase of AREDS 3 trials. So we still they're releasing it to the market beforehand, but we'll have to, it'll probably be another 6 to 8 years before we actually know. But yeah, fingers crossed, right? The kind of, I did have an interesting question, because there's always some debate amongst publications I've seen, and that's the blue light. That's always a topic. I think most eye doctors, they hear a patient come in, they ask them, but what about these blue light glasses? And we all kind of stop and grit our teeth for a second, um, but between, the information about blue light, sunlight exposure, maybe some of the new research on the blue light blocking IOLs they've put in, what is your kind of hot take on the effect of blue light and the risk for AMD?
I think sunlight, like outdoor UV exposure, can definitely reach the retina and be harmful and will cause a lot of like eye damage in general, right? Like cataracts and that. But when it comes to indoor blue level light levels from, say, like light bulbs or like TV, computer screens, I don't think that's anything to be concerned about with regarding AMD in terms of the progression of the disease or anything. Certainly, like blue light blocking glasses may help them be more visually comfortable or see better or something like that. But from in terms of the altering the disease state, it does not. But I think UV protection outside is definitely important.
Yeah, that's basically my takeaway too. I know the kind of nail in the coffin for me was mostly, again, that the IOL study that I think it was like 5 or 8 year data. They did the implants with the blue light blocking IOLs after cataract surgery versus clear just UV blocking IOLs. And after I think 5 years, they found no increased risk at all or advancement in AMD in any of the patients between the two cohorts. So I was like, oh, that's great. That's like super helpful information. But I think it's still, I think sunlight in general is something that it's good to be mindful that, yes, sunlight gives us a lot of things, right? Natural red light and near infrared light, but UV light is still pretty tough on our skin and the eyes.
Mm-hmm, definitely. And I think just conceptually too, when you think about taking lutein zeaxanthin that's included in these like AREDS2 supplements, or like making sure you intently eat like foods high in carotenoids that are like yellowish or orange, it's because you're trying to build up like an internal like UV light protection, right? We're trying to build up that yellowish orange pigment that's in the macula to actually try to absorb and prevent that blue short wavelength light from causing retinal damage. So I like to kind of think of it that way and explain it to patients that way sometimes too.
Well, to kind of just kind of finalize everything a little bit, do you have any final like call to actions for our other eye doctors who may be listening in, whether it be students or residents? Do you have any sort of final kind of tips? Because you're a high level educator in the eye care and retina world. Do you have any sort of kind of final tips, big take homes that we can have?
Yeah, I think in terms of to doctors, like making sure you identify who's at high risk of converting to advanced stage disease is so important. Monitoring those patients more frequently, making sure they're doing home monitoring of some sort that's monocular. A lot of times patients may lose vision when I don't even know until they come into their eye clinic. So emphasizing the importance of that. But multimodal imaging such as OCT, fundus autofluorescence, OCT, and geography we discussed are ways that you can pick up early neovascular exudative AMD. The quicker you detect that, the quicker you refer it out, the more vision you can preserve. So important. But also now with geographic atrophy therapies, and we know treating early helps preserve retina. So catching that early and referring that early is also very important. And to be aware of these evolving therapies for intermediate AMD, other than just supplementation. So like you said, like photobiomodulation therapies, there's some other ones kind of coming like down the line there, but knowing who's most likely to benefit, who's at high risk of progression, has some acuity loss, and knowing which ones to refer, or if you have the device in your practice, which ones are going to most benefit from like those sorts of therapies.
Yeah. And I think it's interesting that you mentioned it because I it didn't even come to me, but the at-home monitoring, right? Because historically, giving out an Amsler grid, that's been sort of the easiest thing to do. But there is some now at-home monitoring kind of advanced. They're almost like mini OCTs people take home. And have you had experience with those technologies?
I have. So for See Home, they actually have a vision monitoring, like sort of metamorphopsia device that's almost like a microperimeter type of thing that a patient can use to detect early metamorphopsia. It is prescribed only. So it's like connected through a monitoring center that for See Home, like Nodal Vision has, that will then alert the prescribing doctor, hey, there's been a change in this patient's responses, get them in for an examination right away so you can see if they've converted. to the neovascular exudative form of the disease, which we want to catch as quickly as possible. But they also have an FDA-approved home OCT right now. It's more applicable for patients who are already in that neovascular wet stage and are undergoing anti-VEGF therapy. And rather than having to, say, go back to the retina specialist to get in, probably wait an hour, then get an OCT, which takes 5 seconds, to tell them, oh, you don't need an injection today, that perhaps the retina specialist could review that data remotely and say, well, things are still looking good. We can forego the injection this month or something like that.
Yeah, I'm going to have to look more into that because I don't have much experience with those devices, but I've seen them either advertised in various publications or at conferences. So something I want to kind of learn more about because I think there could be a lot of utility in that for some of our patients.
Absolutely. There's some insurance coverage too. I mean, for patients who have like intermediate stage AMD, I think it's a great option.
And then for any of our just listeners, viewers who maybe aren't practicing doctors, but they're struggling with this either in their family, a loved one has it, or they struggle with it themselves. Do you have any kind of final kind of tips or key takeaways you think would be helpful for them to hear?
Yeah, I think if you've been diagnosed with macular degeneration yourself, you're having vision difficulties, it's so important to have a support group around you. So when you go to your appointment, if you can bring like a loved one with you, because I think it's hard to digest information when you're kind of in the heat of the moment, you have anxiety and stress, and so I think that's very helpful just for them for moral support for you, but then also to try to remember the education aspect and the communication that you had with what the doctor was trying to tell you about your disease. I wouldn't ignore that, depression is a very common and normal thing to experience with vision impairment and vision loss, like blindness, and so don't be afraid to say, hey, maybe I need to see a counselor. I need to see a psychiatrist because I'm having a whole lot of trouble dealing with this. That's a very common thing. And I think under-recognized on both a patient and doctor platform side. Like we're very fortunate in our hospital setting where we have behavioral health next door. So if I see that a patient is struggling or I sense that they're struggling, I can have a conversation with them and make a referral really easily.
Wow. I think that is really gold because, that's something I don't typically tell my patients to make sure you go with their family, but that's really smart to have somebody there as a support because, it's like drinking from a fire hose, right? A lot of times if you do go to a retina center, you may see an optometrist who works there at the retina center who's maybe screening to decide, we have to send this patient to get a treatment or not. But a lot of times the retina specialists, they only spend 5 minutes with some patients because they have so many people they need to help and treat. And so it can be overwhelming. There's so much going on and so much you don't know. So thank you so much for sharing that. I think that's insightful. Well, from here, Carolyn, Dr. Majcher, thank you so much again for being here and for sharing some of your knowledge. I imagine I'm going to probably be seeing you at one of the upcoming conferences, but I hope that you enjoy the rest of your day, and we'll talk to you soon.
Yeah, thank you so much for having me. Always a pleasure to chat with you, Joey.
Thank you.
You've been listening to the Dr. Eye Health Podcast with Dr. Joseph Allen. For more resources, trusted information, and helpful tools, visit dreyehealth.com. Thanks for joining the community that's focused on healthier eyes and a healthier life. Until next time, stay informed and keep your vision sharp.